Welcome to Health Hour, a session for you by Black doctors, hosted by the Caribbean and African Health Network. Ever sat in a doctor's office thinking, they just don't get it? Or search for health advice online, but you can't understand it? Felt unheard? You're not alone, and you found your solution with Health Hour. Every Saturday at 11 a.m., this is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with the cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
Hello, everyone. Welcome to Health Hour on this fabulous Saturday morning. Welcome, everyone who's joined. While we wait for everyone to connect, if you can tell me where you're joining from and what the weather is like where you are. For me, I'm in London and it's sunny outside. How is everyone doing? Where is everyone joining from? Welcome, everyone. Got a couple of participants already on the call. Let's see, couple joining now, being admitted to inside. Welcome, everyone. Okay, we've got Charles from Manchester. Welcome. It's very sunny there as well. We've got Stephen. Ooh, fabulous. Sunny Salford. Oh, somebody's in another part of Manchester, which is rainy. Okay, welcome, everyone. Just having everyone connecting and joining in. We'll just give it another minute for everyone to connect. Milton Keys, sunny, very nice. I think spring is here and edging into summer. The weather's quite nice. Welcome. Very nice. Good, good, good. Variable looking Kent. I like that. Variable looking. Very nice. Okay, that's funny one. Thank you. Thank you for joining. Okay, so I'm going to start now. I am Natalie Nunes. I'm a consultant obstetrician gynecologist, and I have the absolute pleasure in introducing our speaker today. We've got Miss Karen Joash. She's a senior consultant obstetrician gynecologist at Imperial College Healthcare NHS Trust in London. She has a specialist focus on high-risk obstetrics, perinatal mental health, and preventative women's healthcare. She's the director of the Clinical Academic Training Office at Imperial College Academic Health Science Center, where she leads strategy for developing the next generation of clinical academics and advancing innovation in healthcare. Karen is also a functional medicine expert and entrepreneur. She's a co-founder of Pura Vita, an award-winning doctor-led supplement company focused on optimizing health across the female life course, from fertility and pregnancy through to menopause and longevity. And I certainly recommend it to all my patients. I really do. Her work is deeply rooted in addressing health inequalities and redefining women's health through a life course, systems-based approach. She's widely recognized for her leadership, having received national awards and contributing to major educational and clinical initiatives across the UK. Today, she will be sharing insights on menstrual health, cutting through misinformation, and helping women understand what is truly normal, what is not, and when to seek support. So, we welcome Karen to speak to us today. Thank you.
Hello, everybody. Hello from sunny London. And it's such a pleasure to be here with you. And thank you so much to Dr. Nunes, Natalie, for that fantastic introduction. And really, really just excited to be here with you all. So we're going to delve a little bit deeper. That's my background. I sit on the interface. I think maybe I'm a bit unusual. I have a biochemistry background in master's before I did a medical degree. And then I've also got functional medicine accreditation and specialization. So I've done further sort of postgraduate studies in that as well. So it means it allows me an in-depth layer to look into not just gynecology and clinical approaches, but also a little bit around functional medicine. So what supplements actually make a difference? What does the science say? So today we're going to talk about periods. So much fun. So we're going to start with looking at sort of 10 top myths. Then we'll have a short Q&A, and then we'll carry on with a little bit of a deeper scientific understanding of period issues. So number one, okay, periods should be painless. People presume that just because you have pain, it means there's a problem. Unfortunately, myself and probably many women on the audience have had pain, and it doesn't mean that it's abnormal or that something's always wrong. It's very normal to have some sort of mild discomfort, and that can be physiological due to something called prostaglandins that are released that cause the womb to contract. And create a little bit of crampy type pain. And actually, sometimes that can be confused with bowel pain or lower back pain or pain on the inside of the thigh or pain that runs down the leg. And this can all be linked into just normal period type pain. However, there's always a however. If you have severe pain, you're vomiting or fainting or having to miss work or school, that is not normal and you should seek help. And particularly from the Black experience, we know that women are often dismissed when they go and visit and speak to their doctors. Really important for you to recognize this. And if you're a mother and you've got a daughter, yeah, please be kind if she's saying she needs some time off school, because it may be that something actually is particularly wrong. And it's because it can be linked to endometriosis, adenomyosis, and fibroids, which we'll talk about a little bit later. And remember, women are often told it's normal, and that leads to diagnostic delays of 7 to 10 years, particularly in endometriosis, and we really, really don't want that. Second is thinking that a 28-day cycle is normal for everyone. You shouldn't just have a perfect 28-day cycle. Everybody's got a range. It can be between 21 to 35. There are really good period trackers that you can use to just look at your cycle and understand that there's a beginning phase, which is called the follicular phase, and then the luteal phase. And the variation is different for everybody according to the hypopituitary ovarian axis. And it's different in all of us for different reasons. Stress can affect this. Your energy balance can affect it. So can your thyroid function. But cycle variability is often an early biomarker of systemic health. So if it's becoming very irregular, on and off, don't just think periods. I've always been saying people, when they talk about women's health, they think it's all just about ovaries and a womb. It's far more than that. Actually, our ovaries and our wombs give us insights into underlying health conditions that might possibly be occurring. The other thing to recognize is people often think that you must bleed every month to be healthy. And it's interesting, I often see people not wanting to have the coil or contraceptive pill for that because they're thinking that the blood, which is released every month, is going somewhere or into their body, and it's not. It just simply means that the lining of the womb doesn't build up. That's what the hormones are doing. So there's nothing to shed. So it's not that there's dirty blood that needs to come out or there's a problem. It's just simply that that lining hasn't built up. Menstruation periods they're not a toxic cleansing process. So when you're hearing all these myths on social media, put them to one side. It's completely irrelevant. There's no such detox narrative. It may be going around social media. It's inaccurate, and it's often used for people to market things to you and sell things to you which are inaccurate. Number four, heavy periods are something women just have to tolerate. So periods to a certain extent are normal. So people can have heavy periods can be normal. But if the things that will tell you that are not normal is looking at flooding. So like you're standing in something, you've got a big gush of blood that comes out. That is very heavy. It's unusual. Clots, so you're getting clots that, and when we take clots, we're not talking about tiny little clots that sometimes you may see. We're saying clots that perhaps are like the size of a plum, and are coming out, and exhaustion. They're not normal. So there are, if you're soaking and needing to change your pads every 2 hours, that's abnormal. You need to see the doctor. And when we say soaking, that means the pad is full, not that the pad is just stained, because some people like to change more regularly for their own idea about cleanliness. And as you can see, clots are greater than 2 to 3 centimeters bigger than a plum. So interestingly, the causes sometimes of heavy menstrual bleeding are not necessarily that there's something wrong with the body, but it can be a driver, because the more blood you lose, the more you become anemic, and therefore that blood, the anemia means you have normally lowered iron stores, lower B12 stores, and lower folate stores, and they're important to make the clotting factors that make you clot. So you imagine if you're bleeding heavily, it just becomes this cycle, and then you lead into a condition, as it said there, coagulopathy. That means where your coagulation, your clotting pathway is not working well, and you bleed more. So that's why some women may be given tranexamic acid to help them, and it's really, really important to treat your heavy bleeding with iron, as well as something like the tranexamic acid. And you can see on there's a whole pathway on heavy menstrual bleeding, which you can access, I think, via the patient information portal at the RCOG website, but also from this Cochrane as well. So it's not just a quality of life issue, it can be cardiometabolic, because it can lead into coagulation problems and other issues. So it's not just gynecological. And then number 5, irregular periods are always PCOS. Everybody has an irregular period. There's, lots of PCOS influencers. I'm going to help you sort out your PCOS. Come on, guys. It's so many other reasons that it can happen. It can maybe reflecting thyroid dysfunction. So your thyroid should be checked if you've got irregular periods. It can be high or low, and it can affect it. It can be high prolactin, and that can cause also leaky breasts as well. It can be the perimenopause. Yes, that's another webinar for another day about information that's not always correct. But it can also be this hypothalamic suppression, hypothalamic. That's a structure in the brain. And that can be related to stress, for example, and doesn't necessarily mean sort of mental stress, just physical stress. It can be weight loss, overtraining. It can be even traveling between time zones on an aeroplane, and may trigger that just temporarily. But if it's consistent, it then may give you an insight that there's something that's happening underneath. But PCOS is overdiagnosed online and also under phenotype clinically. I mean, if you are suspecting PCOS, so again, it's a whole other talk. I talk about the different phenotypes of PCOS. Phenotype is a physical expression. So it's not just irregular periods in people, it can be other things that show as well. And keep your questions coming, because about number 10, you can ask a nice set of questions via Natalie. So put them in the chat. So number 6, hormones and enemy. Oh my gosh, all this, let's balance the hormones. I mean, what is hormone balance? You can see hormones link into so many parts of the body, the brain, cardiovascular, joints, muscles, the gut, into your bladder function, the renal function, the list goes on and on. And estrogen and progesterone, they regulate the brain, the bone, cardiovascular system, and symptoms arise not the fact that you have the hormones, but if you're slightly dysregulated for different reasons. It may not actually be the level, it may be stress that's driving it, it may be the way that your hormone receptors work, but you need probably a little bit more depth of a clinical understanding with a doctor, not an influencer, to understand exactly what's happening. And usually blood tests would be our first go-to. Again, number 7, so you can't get pregnant in your period. I hope people are starting to realize that's not true. Look at that circle on the right. It's got so many fertile days. And the reality is you can, because sperm can last up to 5 days, and the egg itself can last up to, between 2 to 3 days. So early ovulation can overlap with menstruation, possibly. And it, unfortunately, sometimes this does drive unintended pregnancy, particularly in younger populations. So really don't think that just because you've got your period, it's a time to have safe sex. And this is really particularly important in this climate where people are using hormonal tracking as a form of contraception. And then number 8, tampons, cups, or products are inherently dangerous. Don't put anything inside of you. That's not true. And the myth is that all internal products are unsafe. I'm also an ambassador for the Women's Environmental Network, and we often raise awareness about period products and the fact that we don't really call them how can I say, in terms of the way that people you think of them as cleanliness products, because period blood is not unclean. But it's important to realize that some products have toxins like lead and other things in them that can actually drive inflammation within the pelvis and drive some of the causes of these illnesses that we're going to talk about a little bit later. But when they're used correctly, it's very rare for you to get toxic shock in syndrome. But the biggest issue is like duration of use and hygiene. And particularly in the black populations, it's over cleaning. So people using things like Dettol to wash with, which could disrupt the microbiome. When you say you disrupt the microbiome, that's the balance of bacteria within the vagina. You kill all the bacteria, but actually we've got a wonderful layer of healthy bacteria that actually fight the harmful ones. So once you do that, it can become dysregulated, and then black women are a bit more prone to have things like bacterial vaginosis. So really sort of that's a fear-based narrative that any sort of discharge from the vaginal area or period blood is unclean, and then internal products are often used inappropriately. So again, another thing is that periods should stop during stress, and that's normal. It's a complete myth. You shouldn't lose your period necessarily just because you're under stress and it's harmless. It does happen, and if it happens, it's telling you something about your body that you have got perhaps a little bit more prone to this metabolic syndrome, this endocrine suppression, and that can be associated with bone loss, infertility in longer term, as well as cardiovascular risk. So there's a little bit of a red flag. It's not just your body adapting, and it's important to flag it and then to think about your own internal health. Number 10, it's again, and it's great that you're here on Health Hour because you found the right source of information. And I would say, particularly sometimes in minoritized communities, because we get pushed away from clinical medicine or health medicine because we feel we're not listened to, we often go into what we call pseudoscience. So getting lots of things about, I don't know, aloe vera being the source and cleansing of everything, garlic or lemon tea or something. You've probably all been there and had all these things sent to you by WhatsApp or even on your algorithm. And then quite interestingly, I'm now seeing on Instagram accounts pop up where you can say it's an AI bot who's doing all the information, and it's just like nonsense that it's, you know, they have hundreds of thousands of followers, and you can see that the information isn't correct. So really, it's a myth that they can replace medical evaluation, but they have important roles. And I will go through some of the important nutrition and supplements that you need to think about in the context of menstrual health. But the danger is that sometimes you get false reassurance and delayed investigation. Don't be scared of going to see the doctor. Use your professionals on Health Hour to support you in how to navigate the health system. But when it comes to science, really important to embrace criticism of that. So you need to look at it in a really in-depth way to know what's working. Interestingly, AI, things like Claude and ChatGPT are helping to cut through the misinformation. So I do feel we'll go into a phase where you'll be able to see reliable health information will be in your algorithm rather than just influencers. And so this is my little summary table. Feel free to take a screenshot of it because it's quite a lot. So it's just basically a quick comparison between what's normal, not normal. So cycle length, we mentioned, is between 21 to 35 days. That's relatively consistent. Your cycle can vary between 2 to 3 days on average. If you're skipping months or there's sudden change or very irregular, it's not normal, then you can start to think about things like polycystic ovaries and thyroid disorders. And then in terms of bleeding, we hadn't mentioned that before. So it's normally between 3 to 7 days, sorry. If it's less than 2 days, more than 8 days, that's quite abnormal as well, and may indicate and that you're actually not ovulating properly, or you've got some hormonal pathology. We've talked about bleeding volume already. We've also talked about pain and clots as well. I'll mention premenstrual syndrome, and that's a mood disorder. It's normally mild mood changes that sometimes people experience with the physical changes. But if you've got severe mood swings, depression, and it may mean that you need to consider premenstrual dysphoric disorder, which is an endocrine disorder. Ovulation signs are very normal, the cervical mucus. If you're not really seeing signs of ovulation, that would be sometimes suggesting maybe you're not releasing an egg each cycle. That's what ovulation is, the release of an egg. And then you shouldn't be having bleeding in between your periods or after intercourse. Any of that is normal and requires urgent assessment for cervical or endometrial problems. That's in the lining of the womb problems. And really shouldn't really impact your life. You may also, in terms of associated symptoms, see mild bloating and fatigue, even maybe a little bit of diarrhea sometimes as well, happens to some people. But severe diarrhea, bleeding from your stool is abnormal, sorry. And dizziness and breathlessness is abnormal as well, may indicate that you're quite anemic. Adolescent cycles, just to know that for 1 to 2 years, when your period first starts, they may be a bit irregular. But if you're over 2 years and your cycles still haven't become regular and you've had large gaps, you do need maybe some blood tests just to check that your endocrine, that's your hormones are normal. And then perimenopause, it's a gradual cycle drop, but if it's very heavy, prolonged, or you've got abnormal bleeding around the menopause, please seek your doctor's advice and you need to be seen early and urgently in a rapid access clinic to exclude cancer or any problems with the lining of the womb. So a little bit of a summary. A healthy period is a vital sign of overall health. So it reflects your hormone or endocrine health, your metabolic state. When we say metabolic, we're thinking about risk factors for diabetes and cardiovascular, blood pressure, and so forth. Also, psychological well-being, as well as your nutrient status and adequacy. So the danger isn't just misinformation; it's normalization of suffering. And the women's cycle is not something to fear, suppress, or to commercialize. It's something to understand, interpret, and respect because it's a sign that our human race continues. I think we're going to have stop briefly there for some questions.
All right, fantastic. Thank you very much. We have a couple of questions for you. The first one, you said cycle lengths can vary. Is it even important to check your cycle length? Do you need to do that? Could you just live your life? Is it important to keep track of your cycle?
I love this, Natalie, because probably you and I, we never checked our cycle lengths. I mean, life has changed so much. You've got all these apps that people can pop into to and check things about everything, even from sleep. I've got a sleep tracker app. And what I would say is that you don't need to do it all the time, but I think it is a good thing if you're looking at your health and longevity, to track it maybe for 3 months and see what it's like. Once you've tracked it for 3 months, you know that it's fine, then, just move on. But it's just another way of assessing things within your health armament, which is really, really important.
Great, thank you very much. So, if I have a trip coming up, what's the best way to delay my period so it doesn't interfere with my trip?
Oh my gosh, people do this all the time. So if you either try not to delay your periods, that's the one thing, because it can cause some instability a few months afterwards. But otherwise, we use northisterone, 5 milligrams, 3 times a day. Your GP can prescribe it for you, or in certain countries, when you arrive, you can just buy it yourself as well.
Okay, great. One other question. Does taking creatinine adjust my cycle?
I'm not aware that it would adjust your cycle. It's creatine rather than creatinine. So creatine is more recently been sort of researched as a really good health supplement. Actually, I do now recommend it to people because it improves muscle mass, also improves brain health, overall really good for metabolic health, just because of the way it drives energy function, such as mitochondrial function at the cellular level. If anything, I would expect it to improve menstrual health and not affect it adversely.
Great. Someone has asked, is it normal to see your period twice a month?
No, it's not normal to see your period twice a month. Normally, the biggest gap is 21 days. So that may mean you start on the first of the month. The next time you can see the period is on the 22nd of the month. So if you're describing that, that is normal with a 21-day gap. However, if you're seeing it like every 2 weeks or less than 21 days, that is not normal. And sometimes what people are seeing is what we call intermenstrual bleeding. So that's bleeding between your actual proper regular cycles. So you're bleeding like every 14 days. And we will be looking for conditions such as polyps or cervical problems, or even sometimes fibroid issues as well.
Yep. So that leads on to another question where someone said, I've heard a doctor say that not all bleeding indicates a period. What does this mean?
That is absolutely correct. So as you've seen I hope you saw the last sort of slide. If you've got bleeding that is in a regular time, you've tracked it, you know your cycle's every 28 days, you should be getting bleeding at the first of the month, and then the next bleed should happen on the 28th of the month, for example. So if you're bleeding and you've had your period and your period lasts for 5 days from day 1 to day 5, and then you get bleeding on day 14, that is not a period blood. That's what we're describing. So the periods are described as regular bleeds, which are the shedding of the line in the womb every sort of 28 days. So in between that, any other bleeding is considered abnormal. And that's what they're describing.
Okay, I'm gonna take, I think maybe one or two other questions we've got here. So, what are the concerns with a thickened endometrium, and what options do women have beyond hysteroscopies for investigation?
So can we hold that question to afterwards? Because I think it will come into some of my abnormality talks I'm
That's
getting on to
fine.
now.
Yeah, and I think in the next question I've got here would also probably be good for after your next section. So I think this is a good time to jump into your next section. Thank
Oh,
you.
fantastic. Thank you, Natalie. Thank you for all the questions. What a great audience. I'm really enjoying this. So some of those questions may not be fully covered, but we'll go back into a Q&A when we do a bit deeper. So what are the period issues that we should be concerned about? So heavy bleeding, which is described as menorrhagia, there've definitely been through that. No bleeding is where you don't see your cycle at all. That's called amenorrhea. Infrequent bleeding is called oligomenorrhea, so you're not bleeding as much. We're talking just about period bleeding here. Painful bleeding is called dysmenorrhea. We've got all these lovely names, haven't we? And then frequent bleeding is called polymenorrhea, you're bleeding too much. Irregular bleeding can be classified as either intermenstrual, that's between your period cycles that we talked about, or it can be after sex, which is called postcoital, and then there's postmenopausal bleeding. And we'll touch on all these very briefly, but we'll come back to them again. So if we look at menstrual disorders, there are so many. We only have 1 hour, so I've chosen maybe the most common ones to dig a bit deeper into. So I'm going to talk a bit more about polyps, polycystic ovaries, endometriosis, and fibroids. So let's see where it takes us. And as you can see, there are so many other things that we're considering. Endometrial dysplasia, which is a bit about the question that was just asked, together with cancer, pelvic infection, deficiency disorders. I keep coming back to that because people often leave that off. Hormone disturbance, adenomyosis, bleeding disorders, the coagulation I described earlier. So let's dig a bit deeper. So low frequency disorders are often related to hormone, chronic illness, metabolic, stress response, and weight loss. I've mentioned that before. And then when we're thinking about painful periods, these are often related to conditions which have either affect the structure of the womb or the way the womb contracts. Think of those two things. So adenomyosis is a disorder of the lining of the muscular part of the outside of the womb, which means when the womb wants to contract when you have a period, because the muscle is not perfectly aligned, it causes disordered contractions. So rather than the smooth contractions, you can get like a twisting action and it causes lots of pain. Fibroids, a lot of us know, it's an outgrowth in the lining, again, of the muscular part of the womb. I'll show you some diagrams in a bit. And then that also can affect bleeding and also pain. Hormone or prostaglandins, the hormones can link into another system called the prostaglandin system, which are chemical messengers to the womb. If these are disrupted or overexpressed, they can cause overcontraction and pain. Endometriosis, we will talk about again, is something where the lining of the womb sheds into the abdomen. It doesn't come out through the cervix and vagina. It goes through the tubes and then deposits on the outside. So imagine how painful that can be, because when people start to bleed, they bleed basically internally as well and causes pain. And that can lead to pelvic adhesions like scar tissue, and also it doesn't necessarily lead to infections, but infections can exist as another reason for painful periods. So polycystic ovary syndrome, I went into this because it's probably about 1 in 10 of us truly have it. More people think they have it and they don't. As you can see, those are the stats there. It's one of the most common endocrine hormone problem affecting women of reproductive age. It can be overexpressed within the Black or minoritized populations because we know a driver of PCOS is metabolic illness, and we are more prone to it because of the higher cortisol that our communities express due to living in white communities and the psychological impact of racism. So when we look at the polycystic ovary, you can see that a normal ovary is seen on the right. But in polycystic ovaries, the reason why it's called that is because every month, the normal metabolic hormonal triggers that should cause that ovary to be released, it doesn't work. And so therefore, the egg stays behind. So people have a cycle which can be irregular because the importance of that egg being released is leading to the hormonal balance. So when you do a scan, just to see a normal ovary looks like this on the left, it looks like that on the right. So just to recognize it doesn't cause torsion, it doesn't cause pain because people think it does. Very unlikely to cause torsion unless it's a really, really big polycystic ovary. But often people think it does. You get referred, people say, I've got polycystic ovaries, maybe it's causing pain. That's not a feature of this syndrome. So this is the metabolic syndrome. I'll mention that briefly because I don't want to be too scientific. But an insulin-like growth factor is something which inhibits ovulation or egg release, and it's insensitive. The ovary becomes insensitive to it. It lowers something called the sex hormone binding globulin, which further increases the insulin-like growth factor, and it leads to an increase in androgens, that's testosterone, which increases hair growth. This can be converted back to estrogen. It feeds back to the brain and lowers the FSH. You know, it's a whole cycle of hormonal impact. And therefore, it also leads to insulin resistance. So blood sugar levels are raised. So really important for you to recognize that it's not just an issue that affects the ovaries, it's the whole body that's affected. And those are the hormone imbalances I just mentioned. So it's important to actually keep a diary because you go into different phenotypes. I haven't mentioned it on this webinar. I could do a whole webinar on PCOS, but some people have more of an androgenic factor. Some have more of a hypothalamic. That's mean it's affected more from the brain. Some people are more affected from a fertility perspective. So it depends on what affects you. And some people are affected also more from mood because of all the impact of where the mood works. Now, the reason why I've also highlighted is because people don't realize the long-term effects of PCOS. It's high risk of diabetes, long-term, also high risk of gestational diabetes, diabetes in pregnancy, high risk of cardiovascular problems, including raised blood pressure, because of that way that cycles has worked with that insulin insensitivity, the cortisol levels that are changed as well, which then lead to more weight gain or difficulty losing weight. Which then can lead to this risk of obstructive sleep apnea, the snoring, higher risk of cholesterol and lipids, fertility issues, risk of endometrial cancer because it's a relatively high estrogen state, which means it drives proliferation and growth of the lining of the womb. And this is an issue when it doesn't shed. If you haven't shed the lining within 3 months, it's an increased risk of endometrial changes, thickening, you can see here on the scan, and therefore sometimes a condition called hyperplasia, and very rarely a risk of cancer. So it's really important that once you've established regular periods, you should be bleeding at least every 3 months. If you don't bleed, we would normally say to see your GP to give you tablets to make you bleed. And that's the northestrone we discussed about the period stop for traveling. So here's a simple sort of slide that tells you what you should have been done at the basic level. I always do, for all my women, a scan, hormones, lipid profile, do HbA1c, a thyroid profile because it's more thyroid dysfunction can be linked as well, blood pressure, urine dipstick, and you can do either ovulation tests just to see whether people are ovulating, or you can do blood tests. But I think ovulation tests are a little bit more efficient because you can do them at home. These are the type of things that you would do to support people. This is number 7 is a very outdated treatment, but it's something that used to be done. People are moving more into metabolic support, giving things such as metformin, letrozole, and lipid control. That's making sure your lipids aren't high. That's at number 8 at the bottom, just because we recognize it can reset the baseline of the way the body's functioning and help the PCOS to recover. PCOS never completely, it can revert and go back to almost looking ovaries. And I've definitely seen that in some of my women with lifestyle measures, such as myoinositol, and I'll discuss that a little bit later briefly. But it never fully goes away. So it's important to have an annual check to make sure that things are sorted. The first two are just really putting a sticky plaster over the condition. So you give people pills just so that they bleed, but actually they are still got the underlying condition. So when they stop the pills and they want to become pregnant, it can become an issue. So I strongly recommend some sort of lifestyle measure or metabolic support, 5 or 8, to ensure that your fertility is preserved or maintained for your future plans. On to uterine polyps. So people, I run a clinic where I sort of deal with polyps every week, and they are so common. So they are the lining of the womb on the inside of the womb, the redder area, overgrows, normally under the influence of a lot of estrogen, and you get these little outpouchings. So these little outpouchings are called uterine polyps, and they can bleed when you don't have your period. And that's why if you've got bleeding in between, you should be assessed to see if you have them. So they can cause that intermenstrual bleeding when you don't have your period. They can also lead to postmenopausal bleeding, but they can also be a trigger for heavy or irregular periods. But they can be asymptomatic. But the other thing to note is that they can cause infertility. So they're relatively benign. They're not cancer or any problems like that, but they can affect implantation in women of reproductive age. So really important to think about this if you've got abnormal bleeding and you're trying to get pregnant. So that's what a polyp would look like when I'm doing a hysteroscopy test. As you can see, it's just a quick outpouch, and then you gently just take it off through the cervix. I'll show you a diagram in a minute. That's the definitive treatment, and it should be done under direct vision. We used to do them with actually not really seeing where they were, then just putting something in to try and see if we could grab it. But as you can imagine, lots of them would recur. It's very unusual, sorry, let's just go back to that. Very unusual to get cancer, although people worry about it. But the reason why we like to remove features that can consider possible cancer is if it's in the postmenopausal bleeding, or it's linked to tamoxifen use when women have had breast cancer, or if the polyp is very large. But again, I rarely see cancer, and I've been taking these out for more than 15 years as a consultant. So that's the technique. You put a speculum in, or that we actually don't use a speculum anymore. You thread the camera through the vagina up through to the cervix, look for the polyp, and you remove it. And as you can see, the overall malignancy risk is lower, but higher in those groups I just mentioned. So fibroids are another big topic for Black women, overexpressed 2 to 3 times more. There are lots of theories around it. Theories I have linked to, as I've said, the metabolic syndrome. We have more of a stressful metabolic profile because of the environments we live in. Also, use of estrogen type foods. Also, there's some emergent evidence around things like hair relaxers as well that contain certain chemicals that can drive the growth of fibroids too. And so if we look at the fibroids, these are different types. Intramural is the one on the right-hand side, that's within the wall of the womb. Subserosal are the ones on the outside. Usually they don't cause many problems. They project from the outside of the womb because they're not affecting the line of the womb, but if they're very big, they can press the structures inside the abdomen, such as the bladder or the bowel, and cause constipation or frequency of urine. Pedunculated, attached by a stalk, again, not too many problems unless it twists and can become, then cuts off its blood supply and cause extreme pain. And we know that when fibroids have got calcification on scan on the outside, it means they have outgrown their blood supply and hopefully won't grow anymore and stay that size. And so, I'm sorry, this one looks a little bit, I'm just going to show you about the intracavity fibroids. So these are the ones on the inside the womb. We worry more about these because they can cause problems with fertility. So just as we talked about the polyps before, these are the ones that cause problems with fertility. So we normally recommend for them to be removed. And they're the ones that Natalie and I often do frequently in our practice. Natalie's a great gynecologist. She does lots of stuff to do with the snata, that's intracavity fibroid ablation, where she will use that technique on that image I showed before, but heat is passed down, is used to prick into the fibroid and to basically cauterize or kill off that tissue, and slowly it shrinks and grows away. And then also the subserosal fibroids, the ones on the outside, we mentioned they're often asymptomatic symptoms when they're large. They can cause lots of abdominal distension, looking like you're pregnant. That can also be the same for the intramural if they're very large as well. And the pressure effects I've mentioned as well. Interestingly, the ones on the outside, the subserosal, don't really cause much of an effect on menstruation unless you've got fibroids on the inside as well. And so I've got some women who have got subserosal really quite large with normal periods, and they have normal pregnancies and fertility. So as we know, all these things are very individualized, and we would normally recommend fibroid mapping to know exactly what to do. So this submucosal fibroid, as we can see here, heavy sort of menstrual bleeding is often the indicator. So I do quite a few of these, and I mentioned also Natalie does another technique too, as well as doing these. But they can also be associated with recurrent miscarriage because of the way it distorts the endometrial cavity, the inside of the womb, and impaired implantation. And I've mentioned about the ones on the outside, which can cause pedunculated fibroids. The ones that are pedunculated outside, which can cause acute pain, torsion, infarction is cell death, and necrosis is cell death. So when we're looking at calcified fibroids, again, so yeah, the key with this, as you can see, it's in the middle. Sorry, the slide's a little bit odd. But it outgrows its blood supply, and so we therefore see on the X-ray a white area on the outside and acoustic shadowing as well. So here's a little summary. You can take a screenshot of this if you want to, if you're taking screenshots. So it's just to understand the impact of each one. So if it's intramural, bleeding may or may not occur, but pain and pressure can be an issue. Moderate impact on fertility. On the outside of the bleeding, on the outside of the womb, bleeding is rarer, but lots of pressure and pain, but minimal impact on fertility. Submucosal, the naughty ones that cause lots of bleeding, often not as big actually sometimes, cause not that much pain and pressure, but high impact on fertility. Pedunculated, variable impact on fertility, acute if torsion is there, acute pain. Calcified, rare bleeding, variable pain and pressure, and minimal impact on fertility. So that helps you to have a little bit more of a discussion with your doctor about treatment modalities, which can be none. And then also conservatives, again, that's for asymptomatic. So that would be things that I will describe a little bit later, such as the lifestyle type medicine. And there's lots of medical treatments from the Requio, tranexamic acid, progesterone pills, Mirena, interventional treatment with ultrasound radiofrequency, uterine artery embolization, minimal surgical hysteroscopic, the Sonata, major surgical, which is keyhole or open myomectomy, all the way to hysterectomy. But guess what Black women are often told to do? Have a hysterectomy. So you can see there's so much in terms of what you can do before we get to that point. And the other thing is really about thinking about intervention at the really key time. Often I find that women have these interventions just a little bit late, so it impacts on their treatment options for fertility. Don't let the fibroids just get bigger and bigger and bigger. Get an understanding of what your options are so you can suppress that growth before it's too late. And then it becomes the only option is hysterectomy. In fact, the only option is never hysterectomy, but that's what tends to be what's recommended. So let's move on to endometriosis. This is our last set before I'm just trying to finish so we have enough time for the Q&A. So I might go a little bit quicker with this one. But it affects, again, 1 in 10, which is why I thought I'd bring it up for you to understand. So significant negative impact on the quality of life. So it can lead to chronic pain, dysmenorrhea. That's it. So chronic pain is pain all the time, not just when you've got your period. Dysmenorrhea when you have your period, particularly with pain that starts a couple of days before your period. Pain on passing urine, dysuria. Pain on having sex as well, pyroluria, dyschezia, that's all the pain when you're examined. Infertility as well. And estrogen, it's basically an estrogen-related disease. And I think all of these are a bit estrogen-related, all the way from the PCOS that has a dominance. Fibroids, again, are triggered by estrogen as well, and heavy menstrual bleeding, the endometrial lining, the polyps. So we've just really got to get our estrogen balance sorted. So if we, sorry for those who don't like graphic pictures, but here we go. So the uterus is in the middle, you've got left ovary and the right ovary there. So the little dots, everything they're pointing towards are related to endometrial issues. So the redder areas, and we don't expect to be there. So the redder ones are probably a bit more active. The whiter areas where you've got the black arrows are what we call adhesions, where the bleeding has then caused parts of the womb to stick. So it looks tethered. So that's where people get the pain, particularly on intercourse, on movement of the womb when you're examining, or when you have periods, because remember we talked about the contractility or the movement of the uterus, and therefore it will affect things. You can see also this like sort of white teardrop, which is not actually a teardrop. If you touch it, it'll be covered in membrane. It'll be a little bit of a cyst. And you can see on the left ovary, these little blebs or areas, that's also endometriosis, where it's on the actual ovary, and it's bleeding and then causes the bruise and pain there as well. And that can affect ovulation in itself. It can change the environment of the pelvis because it shouldn't really have blood there and cause problems. These are the ways that we grade the endometriosis according to whether it's affected the bowel or found in the bowel, on the bladder, or even other areas as far as lung and liver. And I've dealt with women who've had it in the lung as well. And we need to use a combination of surgical and medical treatment for those. So if you imagine you've got this issue, the principle for, I think, endometriosis, and should be the baseline, despite what you choose to do, should be thinking about reduction in inflammation, because that process, you can imagine, it's driving inflammation and problems within the pelvis. Should be promoting cell repair, antioxidants, thinking about how the prostaglandins can be managed as well, and reduction in bleeding, because if you're bleeding less, then you'll have less deposits and you'll bleed less inside the abdomen, and it will improve symptoms. Also thinking about energy recovery, it can really take its toll on the mitochondrial energy of women, which leads to overall energy loss. And that's where things like creatinine can help, spermidine can help, coenzyme Q10 can help as well. Thinking about your gut health, the microbiome of the gut health, and also mood and pain management, which are really, really key. So these are the treatments, medical treatments. So pills, Mirena calls, all these things that reduce bleeding and stopping periods. You've got the ADVAC HRT as well, and the newer one, Require, which I haven't spelled quite right there. But surgical laparoscopic treatment is often needed to reduce and remove some of the deposits, and then to start the medical treatment straight away so that those deposits don't come back. But then you've got to layer it and have that foundation of lifestyle medicine too. So I wanted just to end with showing you a few scientific studies, just because I want you to understand the difference between influencers and true stuff. So you've got to really understand that there's lots of research out there. So even this with polyphenols as a dietary therapy concept for endometriosis, really, really good stuff. And it links into looking at it at the cellular level. Where do polyphenols come from? Grapes, blueberries, strawberries, all the wonderful, great, wonderful stuff that we were given on the earth to help heal our bodies naturally. And then we know in endometriosis there's increase in local estradiol levels. And there's also what we call progesterone resistance due to reduction of progesterone receptors. Progesterone is important to dampen down that growth of the line in the womb. And if you haven't got the receptors that are telling you to do that, it overgrows. So these are natural things like quercetin, which is another vitamin which I often tell people to take, and really, really helps to link into sort of reduction in some of these sort of estradiol profiles, and also the inflammation as well. And then some other basics: omega-3s, anti-inflammatory; probiotics, anti-inflammatory; exercise is anti-inflammatory; positive psychology, anti-inflammatory; vegetarian diet. Again, it depends though. It does sometimes lower estrogen because of the hormones that are found in meat, but it just depends. If you're eating lots of yam and other phytoestrogens like soya, that drives estrogen, so you just need to be mindful of that. Low nickel diet, which can affect the mucosal areas, and FODMAP diet, which is lowers the fermentation in the gut. So some fermented foods are good for some people, some are not. So it's just been known having that individualized understanding. And the gluten-free diet helps in so many people with endometriosis, and I think it's because of the inflammatory impact. So there's a summary of what you should be thinking about when you're not looking just at the medical: exercise, rest, relaxation, dietary and functional medicine. And then these are the supplements that I love. These are probably a few of my basic ones I tell people about. I've told you about the quercetin. That's great in endometriosis. We know it also works in PCOS as well, because the insulin reduction, myo-inositol PCOS helps improve ovulation because it helps the ovary be more sensitive to that insulin-like growth factor, which I talked about. Beetroot's high nitrates improves blood flow. So actually really good in periods overall for period pain, even if there's no underlying problem. But we know it's also very good in PCOS as well. Magnesium, really important in all cellular functions, and it also helps modify glucose level. Seed cycling, not many people know about that. So that's really day sort of 1 to 14, it should say there, not 1 to 4. That's a tablespoon of flaxseed and pumpkin seed. That's your estrogen promoting seeds. And then sunflower and sesame seeds, your progesterone promoting seeds. So it helps give you a more regular cycle. Some people find just with that, their PCOS improves dramatically because they're helping the body to get that hormonal cycle in the right way. Probiotics, I mentioned before, chromium can also increase fertility and modify sugar levels, and then also collagen there as well. So dietary stuff, again, I could talk about diet all day. And I think, to be honest with you, most of us know what to do. And I'll say the bottom line is listen to your body. So, for example, I talk about water, and that the minute you'll start to feel thirsty, you're already 2% dehydrated, which can link into brain issues like concentration, tiredness, metabolic processes shut down. So don't let yourself be thirsty. But again, it's not about drinking 2 logs of big water in one go. Having water throughout the day that hydrates your brain, all your organs, and also helps the metabolic processes to work really well. And then when you're thinking about sort of dietary stuff, just think about what you eat. So, for example, you may be very hungry, you eat something that's very sugary, and you feel okay because you get that sugar boost, and then suddenly you feel really tired. That's the overshoot of insulin. So it's really easy to actually think to yourself, what did I eat? How did I feel? And if you do that, you can work out very quickly what works for you, even, for example, right down to bloating. Think about portion reduction. So just reducing down either your carbs, making sure you're always having a really high protein meal. You should have at least think about your body weight. It should be at least the same as your body weight, split throughout the day, or at least 1.5 times your body weight. Intermittent fasting also works really well for some of the sort of cellular processes, for brain health, for gut health. But you don't have to restrict yourself to that extent. It sounds like it's long, but it can be simply saying, I'm not going to eat after 6:30, and then I will eat again at 8 a.m. That gives you quite a long fasting window of about 14 hours. And then if you're hungry in the night, have nuts or seeds or something high in protein like Greek yogurt with some berries on it. Increasing your protein intake, also really important in your muscle maintenance, but also metabolic health, which then links into all these menstrual health conditions we discussed about. And soya bean, again, we've talked about that before, but it also decreases the level of testosterone. So it's the way that we eat it whole that can also make a difference. Sometimes soya milk will drive your increase in estrogen. Superfoods, I can go on again. I love things like turmeric, garlic, ginger. They help feed your healthy bacteria in your gut and also in the vaginal microbiome, which leads to longer, better overall health. And then healthy fats, I've mentioned about nuts and seeds, but these also include things like your avocado, your eggs, salmon, mackerel, and olive oil. And there are a lot of natural, I would say, foods that we eat from our communities that are very healthy because we cook food from fresh. The balance that we need to have sometimes is just that we need to not have an excess of the food, but generally it's better than eating processed foods, which we know drives gut dysbiosis and problems. And then we also need to think about relaxation. Relaxation can be in the form of rest, which is important, spending time with loved ones, with friends. But oftentimes in our communities, we're often striving to work and to accomplish, which can really knock off our stress levels, our cortisol, which drives metabolic illness and problems. So really important to think about simple things you do at home. If you're somebody who's also spiritual, you can incorporate that even with sort of things like breathing when you're praying, doing mindfulness, even as you walk. That's your deep breathing that switches on your vagal nerve, gratitude journaling as well. So I'm hopefully coming to the end. So I thought I'd give you a quick summary of the key top 10 supplements I recommend for these conditions. So PCOS, I kept mentioning that about insulin resistance, hypoandrogenism, chronic inflammation, but also here it should say lipid dysfunction. So my inositol, I recommend omega-3 and acetylcysteine. It's a great, great, great one. But I can also add on coenzyme Q10 to that as well. Endometrial polyps, again, you're thinking about the estrogen dominance and inflammation. So DIM is a supplement that helps to reduce that inflammation. Curcumin is your turmeric, omega-3 fatty acids. Fibroids can be driven, interestingly, by vitamin D deficiency. And we know that's more prone in people with darker skin, so it can be one of the drivers of increased fibroids as well. Green tea, I love. I drink it all the time. Anti-proliferative in terms of fibroids, and we know N-acetylcysteine really good. It reduces the oxidative processes and can shrink the fibroid volume as well. And that would be between 600 to about 1,000 milligrams a day. And endometriosis, I did mention quercetin before, but I'll add on the NAC, omega again, and the curcumin into that too. I've come to the end, everybody. So hopefully we've got time for questions. Just for you to know that I very much love clinical medicine. I've obviously got my private practice at the Portland, the Lindo, and Queen Charlotte's. I am quite full, so I will refer to wonderful people like Dr. Natalie Nunez or other colleagues that I work with. But I also very much passionate about functional health medicine. Follow me on Instagram or on LinkedIn, and just watch out for our book release, which is coming out in the year, which is entitled The Black Women's Health Bible, and where we do dig deeper into some of these concepts together with the lifestyle function, but look at it from the lens of the Black woman in particular. We did choose to do that because we think that we are most disadvantaged, and if we really focus on the experience of the Black woman within the women's healthcare setting, we will get it actually better for everybody. If you live near Hampton Hill, please feel free to drop down to the high street and visit us, because we also have a health company in the store. And the products I would recommend for use for any of these conditions include the O capsule, which is designed for ovarian health, the Protect capsule, which is the probiotic, Energy capsule, which helps to get rid of those deficiencies or vitamin problems I mentioned, Vitality capsules, an all-rounder. And we also have a new collagen range coming out towards the end of the month, which has got different ones with turmeric, mushrooms, beetroot, pomegranate, all scientific and evidence-based. But thank you so much for listening, and I'll hand over to Natalie.
Wow, fantastic. What a great talk. Thank you so much, Karen. I like the breadth of it, not just the research, but the supplements, the functional medicine, everything all together to make us happier and healthier with our menstrual health. So I'm going to jump back to that question we'd had earlier. What are the concerns with a thickened endometrium, and what options do women have beyond hysteroscopies for investigation?
Oh, thank you so much, Natalie. So that's a fantastic question to whoever asked that. So endometrial thickening, and now you know from the sort of stuff we've just discussed, actually can be healthy within limits. It depends at what reproductive stage of your cycle you are. But it can also indicate something such as a polyp or fibroids, or a condition called endometrial hyperplasia, or very rarely cancer. So you could do just nothing. You could have surveillance if you wanted to. However, it's just understanding that if you haven't got that histology, you don't really know what's happening. So we do also recommend in clinic, you could undergo a condition called a PIPEL, where you don't need a hysteroscopy. A PIPEL can be simply done by threading a little tube through the cervix and just aspirating and sucking out some tissue. If you feel that you're somebody that's uncomfortable, you can ask for some local anesthetic gel, or even a local anesthetic injection to make sure that that isn't too uncomfortable. But I must say, and Natalie, you probably find that most people find that a bit more uncomfortable than a hysteroscopy.
True.
Yeah, the
Yeah.
hysteroscopies are a little bit easier, because I think maybe it's the medication we give to people around it, probably. Yeah,
Maybe.
but that's really your option. So simple surveillance, or PIPEL, or just find a doctor that you feel comfortable with that will take you through that procedure that you need. Because oftentimes it's because we're scared of things that we don't do them. So I have many women coming into my hysteroscopy clinic, literally teary and shaky, and they leave smiling, saying, "I didn't think it would be that easy," because there's a lot of social media misinformation that scares them off the procedure.
Yeah. Very, very true. Um, Next question. In perimenopause, what is your definition of erratic bleeding? Let's start with that bit, and then I'll give you the second part of the question.
So this is the sort of time period in your reproductive life where, and Natalie and I will probably both find that people often get missed with diagnosis of cancer. So erratic bleeding is somebody who's not having, is not about you having what we call a wider gap between your cycles. It could be somebody who has a bleed, on the first of the month, and then they're bleeding on the 19th of the month. Then they don't bleed for 2 months, and then they're bleeding again for another, a time, and then another 10 days later they're bleeding, or they're bleeding for longer than expected. So rather than bleeding up to 7 days, they're bleeding for 10 days or 14 days, or even up to a month non-stop bleeding, or bleeding after intercourse. So essentially, those are the women that need a scan. A scan is a very simple intervention to check for any abnormality, and that's what we would normally recommend. And it enables us to know about the thickness of the line in the womb, and then we can give you the right information about what to do next. And it also helps to pick up women who may be within that group, unfortunately, who do have endometrial cancer that can be picked up quickly, or even cervical cancer as well.
Mhm. And then they went on to say if your period length is not consistent after 3 months of observation following stopping the pill, does it suggest perimenopause?
So again, it's no, not necessarily. I know people rush towards that. And it's so interesting, Natalie. I think we probably watch this space. Nobody used to even think about the perimenopause. Now it's become such a big thing. Um, but there are so many other reasons that it can be irregular. But of course, that will always be in the differential consideration. But I would say think about metabolic dysfunction first, because that's more likely to be a driver, particularly in a woman who's under 45. So it's normally age related. Very unusual to start going through the perimenopause before 45.
Mhm.
But at 45, yes, it'll be a highest in your differential. So just ask for other considerations. Your thyroid needs to be checked. Nutrient deficiencies need to be checked. Look at the prolactin, look at the HbA1c for insulin deficiency. Think about a dietary change or a modification. And often with these little hacks, I see things recover. In Black women, unfortunately, we do have what we call weathering, biological weathering. If you haven't heard about it before, go away and Google it. It's something which means that we have higher cortisol levels despite all the lovely things that we do. It's just the impact of living in a world that often doesn't see us or doesn't want us there. That's the reality of it. I don't really care if people don't want me anymore, but I'll move beyond that. But in our lifestyle, even as we grow up within that, affects us, little hits on the way people perceive you or your career. So the cortisol then goes up, the metabolic dysfunction sets in, and it could cause ovarian aging. So we know Black women unfortunately do go into menopause earlier and for longer. I've had hot flushes for 10 years. Yeah, and that's, I know, as a course of some of the issues and the way in which I live. Oftentimes people will see Natalie and I and think, oh, they've got it made. But sometimes when you go into certain places where you're not necessarily supposed to be there, you do encounter higher levels of stress. But we do it all for you guys. We love you all. So to come back to what a solution for that is well, I developed the OCAPs actually to think about ovarian health and to reduce premature ovarian aging. And I was thinking about Black women in particular. It has worked well for quite a few of my colleagues and friends who have tried it, and women do love it, and they see their periods are starting to return back to normal with it. So do give it a go. It's on subscription on our website as well. And for those of you who want a code, and maybe I probably won't say it out loud, but anyway, you can message me on Instagram. I'll send you a code for the website if you want to buy something from it.
Okay, great. Good, good, good. Okay, so we've gone over time a little bit, but we've
Mm,
got some really good questions, so we're just gonna whiz through some of these.
mhm,
Um, there's a mother here who's concerned about her daughter, who is
mhm.
only 10 at the moment, and she's concerned that because she had very heavy, painful periods, whether her daughter will have those as well. And are there any natural remedies or exercises that can help?
Yeah, no, it's a really good one. So, her daughter's 10 at the moment, so still very young. There are some things which are more likely to occur in families. We know that endometriosis can occur more likely, whether it's to do something with some dysregulation of way that the lining forms, which is inheritable, and also sometimes with fibroids. But it's just unusual for it to start a little bit younger. But you want to be thinking about the seed cycling that we talked about. It's a really good way to start. That helps for it's very natural, very low level. And then also really think about anti-inflammatories. So giving omega, making sure the vitamin D is at high level. So these are very basic things that people just, we overlook them. But if you look into the science around them, they're really brilliant for the immune system. And then thinking about the real sort of the dietary things, your flax seeds, your making sure that she's eating lots of the rainbow, so the antioxidants, the polyphenols. And then when she has the period herself, thinking about things like the beetroot with the nitrate that helps reduce some of that prostaglandin stuff with the contractions. Some people also like Agnus castus, which promotes progesterone as well. And really good sort of natural things that you can start for somebody who's young in that way.
Okay. We've got someone with fibroids and with very heavy periods, soiling clothes, having embarrassing accidents happening. They would like to know what should they expect from a proper assessment and what support and treatment should be available to help them manage this.
Yeah, really, really good question. So your doctor should do a full blood screen for you. They should look at your anemia level in particular, but they should also look at your stores. And the stores, which they often just do are iron, but they should do the B12 and the folate. And then we've mentioned about vitamin D being associated with fibroids. They should do your vitamin D level. They should also do your thyroid levels as well. And then if you've got any bladder or bowel symptoms, I would expect them to do a liver function and also a renal profile as well to exclude any issues. And then maybe also a urinary test. And then when we're coming on to imaging, we should expect a trans-abdominal, that's through the tummy, and transvaginal ultrasound scan. Natalie's very good at those. I also do those as well. And that would be by a high-level practitioner. And if you've got multiple fibroids, it's often very difficult to see through that modality of scanning alone. So then a pelvic MRI would be the next one to do what we call fibroid mapping to understand exactly what's going on. And often once we understand the fibroids, particularly with heavy period, we will often find there's some element of the uterine lining being displaced, and we talked about that. And then you could be referred for treatment such as the hysteroscopy or the sonata, just to help sort of manage those symptoms. But those are the sort of the main investigations that we would recommend. Not very difficult, very easy to ask for, and should be done promptly as well.
Yeah, yeah, absolutely. Thank you. We have someone who's 21 years old and she's been using the pill continuously with an odd break, but now when she takes a break, she can bleed for weeks, or over a month. She bled for 8 weeks at one point, and she's tired. It's affecting her. Her scan is normal. What else could it be?
So with somebody of that, so obviously you're 21, I'm not sure how long you've been taking the pill or why you took it. Your scan's normal, but that reflects estrogen dominance from what you're describing. So somebody where you've just got the line in the womb that's just been is proliferating and deeding, and actually a little bit of progesterone instability. So I would think for you to start to think about how you can approach that from a dietary or nutritional perspective. But for myself, I would often, and Natalie and I probably would prescribe progesterone treatment for a short to medium period of time and then would stop it. And there's also a method of giving progesterone where you can give it from day 14 to day 28 of the cycle, that luteal phase, where you're describing that you've got some lowered progesterone activity. I must say also from my work, I also do some epigenetic testing. So I work with a company called DNA Life who look at altered expressions of genes in people, and they do have a test called DNA hormones, and it's great. I think it costs less than £200, but you can get a whole profile that can help you to understand. So, for example, in myself, I know I've always been low in vitamin D. It's been a challenge. I thought it's just because I'm black and I work in a hospital all day, don't get in the sun, any sunshine. But actually, I've got altered vitamin D receptor status. So it means I'm even more prone to vitamin D deficiency. So I need to take more. And in some other patients that I've measured, they've got low progesterone receptor expression, which means that they need more progesterone in their luteal phase, and that's a certain factor. So it gives you some really in-depth information. So that's another whole, I think that's another whole webinar. It's talking about the kind of whole science of our individualized, personalized medicine as well, which you can perhaps consider too.
Brilliant. Thank you for sharing that. I better get mine done. Okay, so how long do the benefits of fibroid embolization last? And once problematic symptoms start again, what should be done next?
So fibrin embolization, to explain to everybody, is a condition, is a treatment, sorry, where it's done by a radiologist. They would access the arteries, usually through the groin, and then looking at imaging, they would thread up a little wire to find the artery that's feeding that fibroid, and then they would apply some beads to block off that artery, which will block off the arterial supply to that fibroid, and the fibroid will die and shrink away. So that fibroid doesn't actually return. The issue is that somebody who's had that may have another fibroid that may occur. It's less likely, I will say, because we know that when some of the arterial supplies have been reduced to the uterus, it usually would reduce the tendency for that uterus to have enough blood supply to produce another big fibroid. But so we will consider that as a definitive treatment for that fibroid. But later on, that person may get other fibroids, and depending on their location, you decide what treatment's needed at that time.
Okay, so we've got a question about premature ovarian failure or early menopause in a teenager.
Mm.
Um, what could possibly cause it in such
I'm
a young?
very, yeah, I'm really concerned to hear that. That's very, very unusual. We don't hear of premature ovarian failure in teenagers. So it may be another endocrine condition that needs urgent sort of investigation by an endocrinologist together with a gynecologist. But usually they will need a full endocrine panel, perhaps even brain imaging as well, just to work out exactly what's going on there, because that's not normal. When we talk about premature ovarian failure, we're normally talking about people perhaps in their, early 30s or late 20s maybe, but not teenagers. So there's something else going on there.
Yep. Good. We've got someone who used northestrone and started 3 days before their period was expected, but their period still came.
Hmm.
They're asking, did they need a higher dose? Why did it still come?
Did they start the North East Run just 3 days before?
3 days
Natalie and I
before.
know why. It's just not enough. So
Yeah.
if you're using it for traveling, it may work. But the problem is, even if you miss a dose, it can trigger, and it's 3 times a day usually to have it. But if you're giving it to reduce the amount of bleeding for the periods, normally it needs to be at least 14 days or 10 days minimum before your period starts.
And our final question, someone has asked, is there equivalent team or service like yours, but in Manchester?
Yeah, there's Natalie, but not in Manchester. I mean, obviously, Natalie may do remote consultations. I sometimes do them. As I said, my practice is very full at the moment, but you're welcome to speak to the secretary. But Natalie is amazing as well. I think she may have a bit more capacity at the moment as me, but we can do remote consultations and give you advice and talk to you about how to get second opinions and use your existing imaging. We don't seek to overcharge people. We seek to give you the best health information, support, and advice.
That's right. Thank you very much.
Thank
What a
you.
fantastic session. Thank you very
Yeah.
much, Karen. That was so informative. I hope everyone has gotten their questions answered and have a better understanding of their own menstrual health. I'm going to hand over to Samuel now, who is going to wrap up the session. Thank you.
Hello, everyone. Thank you very much for joining us today. What a fantastic session delivered by both Dr. Karen and Miss Natalie. I'm not sure if you can see me. My virtual background still loading apparently. Hello. Hi.
Hi, we can see you.
Perfect. Okay, I'm just gonna quickly share my slides. Just let you know what's going on in Ghana. Do thank you again for staying on with us past 12 o'clock. It was quite a full session today, so wanted to ensure that we got the best information out there for everyone and answered as much questions as possible. So just bear with me. I'm just sharing my screen. Okay. Bear with me. Big PowerPoint presentation being shared. So if you have been following us on social media over the past few weeks, or at least for a while now, you would have seen that we've been promoting the upcoming Black Healthcare Inequalities Summit. Can you see my slides? Yeah, I hope you can see my slides. We've been promoting the Black Healthcare Inequality Summit that's coming up on Monday. This is happening at the Mermaid, 2 Blackfriars, London. If you've got your confirmation email, please do attend. And if you're unable to attend, please do let us know as soon as possible, because we have a massive waiting list at the moment. So far, we've confirmed 600 attendees, and we look forward to hearing from our confirmed speakers like Dr. Paulette Hamilton, MP, Professor Bola Owolabi, Dame Dr. Marie Gabrielle. This is going to be a fantastic day, and I'm looking forward to being there and supporting the team. We also have the Black Healthcare Awards coming up on the 4th of July. Previously, we've been promoting this upcoming event to celebrate the Black healthcare professionals in the UK. Nominations are now closed, so now it's just get your tickets to support those that have been nominated. If you attended last year and the years before and the year before that, it was a fantastic day. You get to be in the room with amazing people. It's a fun day to celebrate our community. I don't think there's anything like this across the UK for us as a community. So this is why we as Karen decided to bring this forward and make sure that we do it consecutively and find a way to celebrate our people, because we know that we work hard. We know that we are one of the backbones of the NHS and the healthcare services in the UK. So we thought, why not celebrate our people for doing the great work? There are lots of alumni and there are lots of previous winners who would attest to what this recognition means to them. So please use this QR code to scan to get your tickets, and also purchase your tickets, and let your friends know, let your ICBs know, let your colleagues know, let your family know to come along and celebrate with us on the 4th of July in London. And if you need any support, we do provide support, confidential and appropriate support, culturally appropriate as well, within our domestic and advocacy, domestic violence and sexual abuse service, our advocacy service, our home office sessions. We do run here at Karen, family advocacy sessions that we do, again, run here at Karen, and legal drop-in sessions. If you do need any support of any of these kinds, please email advocacy@karen.org.uk. We also run a creative and arts wellbeing service that takes place every Wednesday in Bolton, every Tuesday in Stockport, and every Monday in Gorton. This is a place where you come with yourself, with your friends, family, on your own to, take part in some creative arts, release some energy, release some stress. And these are all culturally appropriate. You get to learn different styles of artwork, and also take part in nature walks, use the garden. Earthing yourself is very important now that we are all very digitized. So please feel free to come down if you're in the local area, and we'll be happy to have you. If you have any questions, please contact Lola at greenandartswellbeing@karen.org.uk. And lastly, just want to mention that we have the Black Red Ribbon Champions. It's important to know that if you are living with HIV, or if you do have any questions about HIV, there's support that's available. We've seen that due to the improvement in scientific studies and medication, that people with HIV can live longer and fuller lives. It's not a taboo as it was back in the day, where people were expected to just wither away and have no contact with the rest of the world. And we're trying to change that and educate people that it's good to get tested, it's good to know your status, and it's good to have the support that's needed. And if you do need some support, please contact BLK Red Ribbon at karen.org.uk. Thank you very much again for listening. We do appreciate you spending this extra time with us, and we do appreciate you tuning in every week. There will be Health Hour next week, same time, same place. Follow us on socials for the topic to be released, and when the topics are released, please do share it with your friends and family and come along and attend. Thank you very much. Have a wonderful Saturday.
And that's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.